Thanks for joining us today. We're going to do a bit of a theme day today on environmental health. I'm really grateful to have been guided through this by some wonderful experts in the field who you will hear from a little bit later, but Dr. Cora Sack, who is one of our wonderful clinician scientists, pulmonologist, environmental health specialists working out of the Department of Environmental and Occupational Health. I think, Cora, you at the Environmental Health Clinic too at Harborview, is that right?
Yep, yeah, the Occupational and Environmental Medicine Clinic, yep.
Awesome, yeah, and we'll hear a little bit more about that later. And then our other expert, Dr. Esther Min, who is a PhD coming to us from the School of Public Health and also the Department of Environmental and Occupational Health, who does a lot of work in the environmental justice realm. And we'll hear more about her work and how we can think about those sorts of issues for our patients later. So to kick us off, though, I'm going to go ahead and get started with a talk on environmental health, sort of a brief introduction and how we can think about it as internists. We'll dive a little bit deeper into one issue with air pollution, and then we'll have Dr. Min talk to us a little bit more about environmental justice. So with that, we will get started. All right. So to start, I have no financial or other conflicts of interest. I am also clearly not an expert at this topic, but as I mentioned, I had some great ones to help me get through this, and we can hopefully tackle it and answer questions you may have as they come up. Our learning objectives today, I split the talk into two parts, the first being this general overview of environmental health, the second part being air pollution. So for this first part, we're going to learn or define environmental health. We'll propose several environmental issues that help us illustrate the scope of environmental health. We're going to give some examples of past and present environmental health events that have been linked with adverse effects on human health. And then we will develop or discuss an approach to environmental health at the bedside. So, sorry, this slide is not working. There we go. All right, so starting with defining environmental health. Of course, there are a lot of different definitions that we might use for environmental health. One example that I really liked when I was doing some research for this talk, mostly for its simplicity, is this one proposed by the WHO in 1989, and they defined it as those aspects of human health and disease that are influenced or determined by factors in the natural and built environments. And if we use that definition or keep that definition in mind, we can kind of expand to think about what topics or issues might be considered within the scope of environmental health. And I'm wondering if folks might be able to unmute or put in the chat anything that they think might be relevant or fall within the scope of environmental health, so we can kind of build up a repertoire or a list to think about. And if somebody would be able to help me look at the chat too, that would be great.
Got some responses rolling in. Karima says chemical farming. Alan says air quality. Andrea says water pollution.
Great. Awesome. Yeah, I think that's a great start. And those are certainly topics that are all relevant for us to think about. This was a list that I came up with. And I would say this isn't exhaustive, but it certainly shows you all the different ways that we might think about environmental health. I think it's really difficult to overstate the breadth of the areas that are relevant here. And I suspect that most of you have encountered, whether or not you realize it, patients whose health has been affected by many of these. And I will also say that these are in no meaningful or rational order, so please don't look for that here. With that said, I think as we're considering the scope or breadth, we can really start to look at the impact more locally and globally. And for those unfamiliar, the Global Burden of Disease Study is a comprehensive global collaboration. It studies disease burden and risk factors for global morbidity and mortality. It's actually largely based out of IHME at UW, but it has funding from the Gates Foundation, and it's actually published in The Lancet with collaboration from the WHO. According to their data, though, at least in 2019, approximately 24%, which approaches 14 million per year of global deaths, are due to modifiable environmental factors. This is unsurprisingly a burden that's disproportionately experienced in low and middle income countries. But I think it's worth noting that the US is not without its own share of issues, and that these issues follow a similar disproportionate burden on historically and presently disadvantaged and discriminated communities. With that in mind, I think we can zoom in and talk about some specific examples of environmental health events. And the first one I wanted to discuss was Flint. Many or all of you are probably familiar to some degree with the water crisis that occurred in Flint. But Flint is a post-industrial city. It has a predominantly Black population. And starting in 2014, they began to experience this water crisis associated with lead toxicity. I'll kind of review the brief timeline of events here, but essentially Flint emergency managers began searching for cheaper water sources, and that led them to, in April 2014, going forward with this temporary change in their water source to the Flint River, whereas they had previously been using Detroit supplied Lake Huron water. And this was intended to be about a 2-year change while they awaited a new pipeline that was to be built in 2016. Fortunately, the Flint River had the water supply from the Flint River had a different degree of lead corrosivity, and this was inadequately treated, which in combination with the aging Flint water distribution system and the high percentage of lead pipes led to images like these. And the upshot of this was that there was a severe increase in water lead levels, which had disproportionate effects on the Black community as well as children and pregnant women there. One interesting thing that I learned here was that children can absorb somewhere around 40 to 50% of an oral dose of water-soluble lead, whereas in adults it's closer to 3 to 10%. So it is something that really does dramatically disproportionately affect children here. If we want to reframe this, though, within the lens of environmental justice, which I will just briefly touch on here, and I'll let Esther tell us more about during her talk, we can think about the sort of 3 domains of injustice that occurred. The first being distributive injustice or distributive justice, in which generally we like to think of the right to equal treatment. So that is to the same distribution of goods and opportunities as anyone else has or is given. And this was violated with an inequitable distribution of a toxic water supply. The second would be procedural justice, in which the right to treatment as an equal, that is not so much equal distribution of some good or opportunity, but to equal concern and respect in the decisions about how these goods and opportunities are distributed. And that was violated with the imposition of emergency managers, which didn't allow for citizens to have a seat at the table. And another interesting statistic I came upon here was that of all the Michigan residents who've lived under emergency management between 2008 and 2013, 71% have been Black. At the same time, though, Michigan citizens who are Black only compose 14% of the state. So a huge disproportionate effect there. And I think the last issue of justice to discuss here is corrective justice, and that refers to the fairness in the way of punishments and how things are corrected. And I think probably all of us were following this to some degree as this was happening, whether it was peripheral or something you were paying close attention to. But this issue obviously went on for years and in some ways is still ongoing. There has not really been good corrective justice here yet. So for the visual learners out there, I think that this or these images, which were taken from actually the first study that was published sort of headlining this issue, can be really illustrative. And these are spatial or maps of Flint that are mapping the predicted blood lead levels following the change in water supply, also shown in written form in the chart in the right. And if we compare it to a demographic map of Flint on the right of non-white population, we can see there's a fairly significant overlap between those red and orange areas where the predicted change in lead levels are greatest. And I think that that is quite telling. Another recent and ongoing case of environmental injustice is occurring in Louisiana. And this is an area that has now been nicknamed Cancer Alley. These are communities of also predominantly Black and lower socioeconomic status citizens who are surrounded by more than 200 petrochemical plants that are emitting toxic waste and byproducts and have now been implicated in staggering increases in local risks for cancer, among other ill health effects. And Cancer Alley here is the red area, sort of in the southeastern part of the state in Louisiana there. And you can see on the maps to the right, the largely, again, Black and more impoverished communities that are living there. Now, to bring it a little bit closer to home, this isn't an issue that's particularly unique to Seattle, but I think it's striking and something that we can all relate to a little bit, is the idea of climate change producing heat islands, which are areas of the built environment disproportionately hotter than others, and also tending to be in communities of predominantly racial and ethnic minorities and lower socioeconomic statuses. So these are maps of King County that were recently published, where volunteers went around and were taking temperatures at varying times of the day. And if you look closely, you can see certain areas of probably generally more affluence, such as Mercer Island or Montlake or Madrona and West Seattle, which tend to experience less severe temperatures compared to some of the other areas in King County. Now, after thinking about all of that, I think what we can start to do is think about how we might be able to apply this information to the patients in front of us. And I would like to review a little bit of history here because even though many of us may have gotten little education about this in medical school or not really thought about it much, it's something that's been on people's minds for a long time. So the 1979 Surgeon General's report on health promotion said there's virtually no major chronic disease to which environmental factors do not contribute, either directly or indirectly. And about 10 years later, the ACP published a position paper in the Annals, which called for internists to take a more active role in considering both occupational and environmental medicine. Some highlights that they included were increasing education on these topics at all training levels, incorporating routine evaluation of exposures in our patients, and then working with public health authorities to mitigate these risks and exposures. I imagine, though, despite that, and despite everything we talked about, some of you may have some reservations or feel like you might not be able to do this with your patients. So I'm curious if anybody has any thoughts as to what might be challenging in having these discussions with your patients.
Andrew threw into the chat, what will they be able to modify realistically?
Great.
Karima says, our education hasn't emphasized environmental awareness, so we don't feel well equipped to discuss these topics.
Yeah, I think those are both really great points. And hopefully we will be able to address some tools for modification for our patients, but I agree with that sentiment. And then similarly, the lack of knowledge. And so here were some of the things that I sort of came up with as challenges, including lack of knowledge or maybe not having any guidelines. And then similarly, we don't know how to discuss these things or what to recommend to patients. And then of course, there's the ever-present things like time constraints that come up in clinic, and how do you decide what to prioritize? Hopefully after this morning, we'll address some of these and provide you some tools to use moving forward. But I think this is a really illustrative of why we need to continue having these conversations and why this is a big issue, because it will affect many of our patients. Now, I will say though, despite some reservations about maybe lack of knowledge or not sure how to talk to our patients about these things, I suspect we all have some experience in discussing things like environmental health. And some things that come to mind as being somewhat related are our discussions of social history with our patients and maybe alcohol, tobacco, or substance use. Similarly, we have probably all had patients who have maybe a fever of unknown origin or a new rash or pulmonary symptom. And when we dive into those symptom-based concerns, we actually start thinking with a sort of environmental or exposure-based lens. And I think that you can borrow that tool set to apply this at the bedside. And I think that that is one intuitive way to do this. You could also think of it maybe as just taking a more robust social history. The caveat here is that this isn't always necessarily to address a specific symptom in front of you, but rather to risk stratify or understand what exposures your patient's having on a regular basis. And this is one mnemonic that I found, which is non-exhaustive certainly, but I think helpful in approaching this with our patients. And it is CH2OPD2, and we'll walk through that. But the C is community, which really gets at where your patient is living. And that would address things like, are they living next to I-5 where there's heavy traffic? Are they near a local dump site? Is it a heavily industrial area? So it's what surrounds them, what is in the area around them. After that, you could start thinking about their home. Whether they own or rent it, what is the shelter that they're staying in right now? Are there renovations ongoing? Has there been lead paint or asbestos or something like that? What is their heat source? What is their water source? Is there mold, and do they have pets? These are all things that are relevant to think about. Also, their hobbies. Hobbies could pose, physical danger depending on what they're doing, but also risk of exposure. So somebody who's into gardening and maybe does use some pesticides or fertilizers, or somebody who works out of their garage to, paint or stain wood. And they're exposed to fumes. These are things that could be relevant to ask your patients. Also their occupation, and not just their present occupation, but their past occupation, because exposure isn't necessarily an acute event, but chronic. And it may take time for things to manifest. Within occupation, you could think about asking about modes of transportation. Are they walking to work, biking, driving, using public transit? All these things may pose different risks of exposure as well. Personal habits. This is probably something that we are commonly used to asking about smoking or alcohol use and other things related to that. Then diet. So within diet, I think of sources of food. Do they have food insecurity? And then where are they getting their food from? Sources of water. Do they drink well water that could have some sort of toxic substance leaching in it? And then also raw foods that may lead to exposure. And then lastly would be drugs. And this is not just prescribed medications, but over-the-counter, herbal, and recreational drug use. And I think using this framework, we really sort of fill out the way we think about how your patient might become exposed to something. So that sort of wraps up the first part of the discussion here. And to remind you, we talked through a definition for environmental health. We looked at a number of environmental health issues that showed us the scope. We talked about some examples of past and present environmental health events. And then last week discussed at least one approach to taking this history at the bedside. And with that, I'll pause quickly to see if there's any questions.
Hey, David, this is Terrence. Thanks for your talk. It's really awesome. One question I had, so my clinic's at the VA, and something that I felt has been like something like an actionable thing is that vets who have been exposed to certain occupational things during their time of service, like we can put them on, or we can refer them to registries. And I feel that's like, feels like somewhat like we're able to do something actionable about that. I'm wondering outside the VA, like kind of non-VA setting, are there these types of registries for certain types of exposures?
Ooh, that's a really good question, Terrence. I might have to throw that over to one of my experts.
Yeah, that's a great question, Terrence. This is Cora. And I work in the occupational environmental medicine clinic at the university. And there's definitely ways that if you think an exposure is contributing to somebody's disease, that there are very set channels that you can use to ensure someone gets recognition of that and compensation. And one method is through opening a worker compensation claim. It can be a little harder if we think that the disease isn't caused by work. For instance, I have some patients with severe asthma who may have a lot of triggers like cold temperatures or stress that are at work, and it isn't necessarily caused by work. And there I've been able to kind of get people protection through the American Disabilities Act and writing accommodations for work that help them avoid those specific exposures. And kind of after David and Esther's talk, I'm happy to kind of go into different resources you might have, or if there are questions that our department would be really happy to try to help you.
Awesome. Thank you so much. Any other questions right now? Cool. All right. We can move on then to the next part of the talk, and then we'll make sure we have a break after this, just so everyone's aware. But now we'll talk about air pollution. And I suspect that after the events of the last several weeks, I may not need to work as hard to convince everyone of its relevance, but I think we should dive in anyway. So our learning objectives for this part of the talk is we're going to identify the major sources of air pollution and the 6 major criteria pollutants. We will determine the major adverse health effects related to air pollution exposure by explaining the hypothesized mechanisms for harm. We will then assess an individual's risk for harm from air pollution using the concepts of vulnerability and susceptibility. And then we're going to integrate all of that into a comprehensive approach for mitigation of adverse effects from air pollution. And to start, we will use this case from clinic. So you are seeing a middle-aged construction worker with ongoing tobacco use and COPD, presenting with shortness of breath, cough, and wheeze, worst at the end of the week. You take a little bit more history, and you find out that they are constructing scaffolding outdoors for a building renovation. It's a job with heavy physical exertion, somewhere around 8 to 10 hours a day. they're working outdoors. There's generally normally low dust levels with this work. They do not tend to wear respiratory PPE. However, there has been poor air quality the last several days related to eastern Washington wildfire smoke. They initially noted irritation in their eyes, nose, and throat. Now they've had progressive shortness of breath, wheeze, and cough. They don't have any sick contacts, fevers, or chills, and they have been using their albuterol inhaler 10 to 12 times a day. We'll step back from that for a second, and we'll think a little bit more about air pollution. So air pollution is any hazardous substance in the air at a level that may cause health effects in living organisms or adverse effects on the natural environment. And really, it exists as this complex mixture of different gases and liquids and particles. And it can be divided into primary air pollutants, which are those emitted directly from a source, while secondary air pollutants are those that are actually formed in the atmosphere through photochemical reactions. And this graphic, I think, is nice because it illustrates the different sources and classifications of pollutants. And really, the dominant sources are byproducts of fossil fuel combustion for motor vehicles, heat and power generation, industrial facilities, agricultural waste sites, and then residential heating and cooking. Natural sources, such as those from wildfire smoke, volcanic eruptions, and dust storms, are generally smaller contributors to air pollution, with the exception of acute events. Air pollutants, at least in the US, are categorized within the framework that it was provided by the Clean Air Act into criteria air pollutants and then toxic air pollutants. The criteria air pollutants are regulated by a standard setting process that requires review of the available data every 5 years. This chart shows 5 of the 6 criteria pollutants: sulfur dioxide, particulate matter of different sizes, nitrogen dioxide, carbon monoxide, and ozone. It also shows their common sources and the national air quality standards that were most recently set by the Clean Air Scientific Advisory Committee. I will say the majority of health effects research tends to be focused on particulate matter, which we classify generally into size of particulate matter, or PM10, PM2.5, and then ultrafine particles. And those measurements are in micrometers. And I'm curious if anyone has a guess as to what the 6th and final major criteria pollutant is. Throw some guesses here in the chat.
Votes all over the board, mostly for either A, C, or F, with a lot of question marks.
All right, love it. Fair enough. That's why we do this. So the 6th criteria pollutant is actually lead. And the reason I didn't include it in the chart here is actually because, fortunately, ambient air levels of lead have dramatically decreased since leaded gasoline was banned in the 70s. That isn't to say that these other substances are not things to worry about, but it's not considered one of the criteria air pollutants that's with this standard setting process. I will say the good news is that pollutant concentrations have been decreasing over time. So here's a chart with data from the EPA that's demonstrating an overall decrease leading up to 2018. However, the bad news is that despite those decreases, air pollution remains a leading cause of global morbidity and mortality. And we see that here in data from the IHME and the Global Burden of Disease study. This is demonstrating relative changes in the measurement here is in disability adjusted life years, or the number of years lost due to ill health, disability, or early death. And we see that there's been a relative increase related to ambient particulate matter pollution. Fortunately, there has been some decrease related to household air pollution there at the bottom. We also see it in actual mortality data. So these are global attributed deaths. This chart is also from the Global Burden of Disease, and I've taken the one for females, although I can tell you the one for males, at least for air pollution, is identical. It's the fourth leading risk factor in both men and women. Finally, we see an unequal percentage of deaths attributed to ambient air pollution across the globe. This graphic just demonstrates the percentage of deaths attributable to ambient air pollution by country. I will note, though, that despite the relative good standing of the United States here, that is still representative of 3 to 5% or so of deaths in the US being considered attributable to ambient air pollution. So if pollutant concentrations appear to be decreasing, why is it that we're still seeing adverse effects from air pollution exposure? Does anyone have any thoughts about that? Feel free to unmute as well.
People throwing in leg effect, cumulative exposure over lifetime as suggestions.
Great, I like those. Yeah, certainly cumulative. This is not necessarily always an acute issue. Some of the things to think about are, there are still billions of people exposed to pollutant levels above the recommended standards. So a decrease, of course, is great, but it doesn't necessarily mean we've hit our goals. Similarly, health effects likely occur when pollutant concentrations are at the upper ends of these standards, and maybe even the middle or lower ends of these standards, and particularly over time. Also, something we'll get into a little bit later is that individuals may have different levels of susceptibility, and these standards are not a one-size-fits-all. And then, unfortunately, we are seeing with concomitant climate change, there is probably some strong interactions here leading to continued effects from air pollution exposure. Next, we'll jump in. Since we now see this is happening, we will talk about what exactly is an adverse health effect and how they may occur due to air pollution. So we'll come back to our case real quick, and we're going to highlight the poor air quality and think a little bit about wildfire smoke. So this is probably not news to anybody, but as an East Coast transplant who came here for residency, I never really internalized the real impacts of wildfires. For much of my life, they were something that I heard on the news was happening in Southern California. And then I got here and suddenly they're up and down the West Coast, and I'm wearing an N95 when I bike to work. So it is certainly a new phenomenon for me, but for many of you, it may not be. But the smoke created from these wildfires contains a number of compounds, many of which are listed here, but this isn't an exhaustive list. And these can dramatically impact those with or without underlying comorbidities. So, and it's also important to recognize that the composition of smoke is highly dependent on the source. So that includes the vegetation, the flame intensity, the transportation of that, and photochemical aging that occurs, which really means that no two air pollution sources or events are going to be exactly the same. That might explain why some people notice more symptoms with one than another, particularly those who are kind of on the borderline of susceptibility. But nonetheless, these are important things to think about. And to understand the health effects of pollutants, we'll start by thinking about some aspects of inhalational toxicology. And that's going to depend on this interplay between exposure and host characteristics. So the pollutant characteristics, such as the size, the solubility, the state it's in, and the concentration that is inhaled will kind of all act together to determine what the actual inhaled dose is. And then the host characteristics, so that would be your rate and depth of ventilation, the unique airway anatomy, any underlying genetic susceptibility, and then individual comorbidities will act together with that inhaled dose to determine the actual impact of or health effect. And here in graphic form, we can just see that smaller, less soluble particles are generally the most likely to deposit deeper in the airways. And that may be one reason why we focus so much on the particulate matter that's less than 2.5 micrometers in diameter. Well, exact pathophysiologic mechanisms aren't really known. There are several hypothesized pathways of injury. So inhaled pollutants may directly injure the airway epithelium. They certainly activate nociceptive receptors in the lungs, and that results in disruptions in autonomic nervous system. They will cause localized and systemic oxidative stress. And then the smallest particles may translocate into the circulation, which means they could cause broader and downstream effects. But thinking about who actually is impacted by air pollution is maybe more challenging and less intuitive. Obviously, these effects are not very easy to measure, particularly on an individual basis. Many of them will be subclinical, at least initially. So shorter term exposures can lead to acute effects, whereas the chronic exposures may stack up and be associated with long-term disease risk. In general, we see that smaller subsets of people go from exposure to physiologic changes, to presentation to healthcare, to death. And it's sort of hard to quantify air pollution as a true proximal event because of this. That said, it remains a really important risk factor to consider. Air pollution exposure has been associated with disease in multiple organ systems. It's not just the lungs. You can see here that there's been evidence to suggest it could be associated with nervous system disease, cardiovascular, skin, endocrinopathies, reproductive disease, digestive health, and immune dysfunction. However, unsurprisingly, the majority of deaths due to air pollution have been associated with cardiopulmonary disease. And as we can see here, both with indoor and ambient air pollution, it's primarily ischemic heart disease and stroke that are the leading causes of morbidity and mortality. Importantly, we see a consistent growing evidence base, which shows both short and long-term exposures to airborne particulate matter is associated with higher all-cause cardiopulmonary and ischemic cardiovascular mortality. This has been borne out again and again in the literature, and it is really something that we know to be true at this point. That might lead to the next logical question, though, and that would be who exactly is at risk for this? You obviously have a busy clinic. Air pollution probably doesn't need to be the top of the agenda for every single patient, but who should you discuss it with? Well, air pollution is ubiquitous. It is so at varying degrees. And while there are no known safe levels of exposure per se, nor are there any populations who are immune, I think like many things, there are significant disparities in exposure and adverse outcomes. So to that end, I think it's important to understand the concepts of vulnerability and susceptibility so that we can contextualize an individual's risk for harm. Briefly, person or population's vulnerability refers to their variation in exposure. So we can see here that certain populations might be more vulnerable or more likely to be exposed due to intrinsic risk factors. Maybe they're firefighters, or they work in construction, or perhaps they live near a heavily trafficked road or highway. All these things would increase their likelihood of exposure. Susceptibility, on the other hand, refers to that person or population's variation in response to an exposure. So certain populations may be more susceptible, that is more likely to have an adverse response to an exposure due to their intrinsic risk factors. And these are things like age, comorbidities, and then immune status. So we see that particularly in our children or elderly population, things like underlying cardiopulmonary disease, pregnancy, ongoing smoking, and others. Where we begin to see the highest risk and worst effects of exposure tend to be in people or populations who experience multiple or overlapping risk factors. And unsurprisingly, this tends to be a population where we commonly see environmental racism and injustice playing out. Here are two articles that I pulled from the most recent couple of issues of the ATS, or American Thoracic Society's Blue Journal. And I think these demonstrate nicely this interplay. So the first study is on redlining and its downstream effects on asthma-related outcomes in Black adults. And the second one looked at traffic-related air pollution and incidence of lung cancer. I'd key in here on the final sentence of their conclusion, which says their results also suggest an increased risk of lung cancer among those residing in low socioeconomic status neighborhoods. I don't think that this probably comes as a surprise to most people, but it is important to be reminded of it and to be reflective on these issues when we're seeing our patients. So with all of that in mind, we'll come back to our case and we'll look at risks or factors that may increase our patient's vulnerability, that is the risk of exposure, and susceptibility to the risk of an adverse effect from that exposure. In terms of vulnerability, we can see things like them being an outdoor worker, doing activities with heavy physical exertion and not wearing any respiratory PPE, all would increase the risk of exposure. Their susceptibility is modified by their ongoing smoking and their underlying COPD. And I think probably many of you very quickly diagnosed this patient with a COPD exacerbation. I think the thing that we don't frequently do is attribute it to something like air pollution exposure. We are usually fairly good at looking for an underlying etiology, something like an infection or maybe medication non-adherence, something like that. But what we may not be so good about thinking about is our environmental health risk factors. And in this case, it is very likely this air pollution that has triggered his COPD exacerbation. I'll pause again here for any questions before we finish up with the last part. All right. Well, feel free to drop them in the chat if you think of any as we move on. But we will wrap up by putting everything we've talked about together today and really thinking about what we can do for our patients who are at increased risk here. First, I want to start with an introduction or a review for those of you familiar of the Air Quality Index, or the AQI. This is the principal risk communication tool used by air quality agencies. The AQI is a scale that goes from 0 to 500 and is color-coded into categories of risk. For each individual criteria pollutant, an AQI of 100 generally represents sort of a short-term regulatory standard. Above 100 is where the EPA begins cautioning at-risk groups. And then above 150 is where the EPA begins cautioning unhealthy pollutant levels for the general population. There are important limitations to the AQI. I think it's important to remember that it's based on a single air pollutant rather than being a composite. So you may not have any single pollutant that is above these levels, but if there are mild elevations in multiple pollutants, that could similarly be problematic. Also, different states or countries may develop their own standards, and I think that's just important to keep in mind when interpreting levels. With that background, let's talk a little bit about mitigation. And I think generally these strategies fall into two broad categories: those which are implemented at a community or population level, and those that an individual can do themselves. I don't think anyone would dispute that community level actions, including regulations and laws to reduce emissions, improve air quality, redesign cities and communities to increase green areas, create healthier communities, are really all things we would like to see and would very likely have more meaningful impacts. But these are somewhat, unfortunately, beyond the scope of what I'm going to be able to talk about today, with one small exception. But I do think it's important to remind everyone that public health is our lane. And as physicians, we have a role to advocate for these things. So we can do both. And while we'll talk primarily about personal mitigation strategies, we should absolutely feel like we have a role in advocating for these community level changes. Regarding the personal mitigation strategies, I will say there are a few we'll talk about. There isn't robust evidence for any of them, but overall the risk and the low risk and the high potential for benefit make them really strategies that we should be trying. So a brief example of a more community level or population level mitigation strategy was this temporary and admittedly reactive policy that was placed by the Department of Labor and Industries in Washington State. And this focused on the protection for outdoor workers during wildfire season. It has since lapsed, although they very likely will renew it for next year. But essentially, it is a rule that provides protection for personnel working outdoors for more than 1 hour who may be reasonably expected to be exposed to wildfire smoke. The rule identifies 2 action levels that employers need to implement certain strategies for when the air quality worsens. So these 2 levels are an air quality index of 69 or greater. The employers must communicate wildfire smoke hazards, provide training regarding wildfire smoke, and then provide respirators on request. If the AQI exceeds 101, or rather 100, employers then actually need to change work schedules and allow additional breaks or rest time. They have to allow for the relocation of or reductions in work. And then they have to provide portable air filters and N95 respirators at no cost to the employees. Again, this was a temporary law or rule that is no longer in effect, but it was in effect during wildfire season, although lasted a little longer than the rule. So that said, we'll move on to some personal mitigation strategies, but I do want to give a few important caveats before we proceed. So the first is that we all have some role to play in reducing air pollution, but shifting responsibility onto individuals certainly ignores that this is larger entities like corporations and governments that are the principal polluters. Next, well, we have briefly touched on and will throughout the morning continue to consider injustice and inequities stemming from the intentional and systematic discriminatory societal institutions and policies. This is a topic that deserves its own dedicated discussion, and we'll let that happen a little bit later. And last, many of these recommendations will not be possible for everyone. There are inherent privileges, whether they be economic or schedule flexibility, in being able to employ all of these. But I think it's valuable that we know them. That way we can pick and choose what might work for our patients and have those discussions. So this outlines the evidence that we'll use to grade these personal interventions we discuss. And the upshot is that essentially almost all of these mitigation strategies have evidence levels that are in the C and D range. Many of the studies just haven't been done, or they're non-randomized or observational. That said, as we discussed earlier, the low risk in implementing these makes them really worthwhile. So jumping into them, this is a graphic that I'm borrowing from a paper in the European Respiratory Journal in 2019. And it focused on personal strategies to minimize the effects of air pollution, specifically on respiratory health. But I think that it's easy for us to see that if we're minimizing the effects of air pollution in general, that would be effective for all the adverse outcomes associated with air pollution. And in it, we can see that they've broken down the mitigation strategies into those aimed at reducing risk or exposure to household air pollution, as well as ambient air pollution. They also highlight some effect modifiers, which can be thought of as susceptibility factors on the overall risk. I'm sorry, lost my thought. Factors like smoking that can have additive or multiplicative effects on the overall risk associated with air pollution exposure. And at the bottom, they've, sorry, trigger finger. At the bottom, they've demonstrated some of the populations that we think of as being at elevated risk, which highlights those factors of vulnerability and susceptibility. So we will dive in a little bit more and look first at our household or indoor air pollution exposure. So recommendations for mitigating household and indoor exposures are primarily twofold. The first is to use clean fuels and stoves for indoor cooking and to ensure adequate ventilation. And that might be in the form of a fume or exhaust hoods, windows, fans, or something else that works. There are some small scale, non-crossover intervention type studies that suggest that transitioning away from cooking with solid fuels to electric or clean burning gas stoves can improve respiratory health outcomes in both adults and children. And the Global Initiative for Chronic Obstructive Lung Disease guidelines actually recommend use of non-polluting cooking stoves and efficient ventilation to minimize the exposure to indoor air pollution as a risk factor for developing COPD. It's important to note, though, that this may be expensive, particularly changing to a clean source. And so that is one potentially large barrier we may face, but we should still be having these discussions. The second potential mitigation strategy is the use of air cleaners or purifiers. So there is evidence from mostly randomized crossover intervention studies to support the use of portable air cleaners in reducing respiratory health effects among the general population who are facing regular exposure to household air pollution. Portable air filters fitted with HEPA filters are the most effective for filtering particles at home. But again, these can be expensive and they do require regular maintenance. So we may find some challenges in having these discussions with patients or recommending these strategies. One potentially cheap option to consider is a household air filter fitted to a box fan, as you can see in this picture, which may be a more affordable and way of doing this, and in fact is relatively efficacious at lowering household air pollution levels. Next, we're going to look a little bit closer at ambient air pollution mitigation strategies. And these broadly fall into three categories. The first is really just air quality awareness. And this can come from regulatory monitors such as Air Now, which is the EPA-driven website, or you might, for those who are interested and have the resources, you could get a personal monitor, which companies like Purple Air produce. There is wildfire smoke specific information that is available here locally at the Washington Smoke blog. And they offer reports and forecasts from a variety of sources. Overall, I will say there's not really evidence that's been collected on this intervention. And there may be some limitations, such as missing the individual microenvironment you're in. And of course, the cost or need for standardizing a personal device. I think one of the challenges in getting data here is that just because somebody is aware of their local air quality doesn't necessarily mean that they've modified their behavior accordingly. But it is difficult to modify your behavior without first being aware. So that sort of, oh, sorry, those are the logos of those websites. But that sort of jumps into the next bucket of interventions, and that is behavioral modification. So this really follows naturally from air quality awareness, but it does end up becoming a big issue of inequity. So for those who do have means, whether they be economic or schedule flexibility, you can adjust transportation routes or modalities, or just stay indoors and reduce outdoor activity during high pollution areas and ends. So in one study, participants with COPD or coronary artery disease walked along a crowded street versus a wooded area. And just walking in the wooded area those participants had improved lung function and reduced pulse wave velocities. These benefits were attenuated though in the group that walked in the crowded urban area. Again, these are sort of small studies looking at generally subclinical effects, but I think it is important to note that the evidence, broadly speaking, is mixed, and that is likely because long-term benefits of things like exercise may outweigh an individual exposure event. But I think having this risk-benefit discussion with our patients could be really valuable. Additionally, we should note that depending on things like how well your windows and doors are sealed, there's sort of variable infiltration of outdoor pollutants into the indoors. The last set of recommendations for ambient air pollution are wearing a respirator. So there is evidence that suggests that short-term use may be able to do things like reduce your systolic blood pressure, improve your heart rate variability. There was a study of N95 use for scripted walks in a highly polluted area of Beijing, and that showed reduced systolic blood pressure during the 2-hour walk. There was additionally a trial of patients with coronary artery disease who used N95s, and it decreased their systolic blood pressure and the magnitude of ST depressions when used as much as possible for 48 hours. Few studies, though, have really been performed in areas with lower air pollution levels, and not everywhere has as high levels as, say, that area in Beijing. So this is, again, sort of a discussion to have with our patients and maybe coming up with an idea of thresholds in which we would use it. I think one area we identified a little bit earlier was a lack of clear guidelines, making this challenging. How do we have this discussion with patients? And fortunately, recently, the AHA, or the American Heart Association, has published its clinical framework, which can help guide some interventions we think of in reducing pollutant exposure. And essentially, it comes down to first being aware, so checking your outdoor ambient air quality. And from there, we then stratify based on level of AQI, and particularly the particulate matter less than 2.5 micrometers. If it's quite high, then we're going to tell all of our patients they should be considering acute measures to mitigate their risks, such as staying indoors or wearing respirators. If it's quite low, then we don't need to modify anything. And where it falls sort of in the middle, we need to then think about the actual comorbidities or underlying susceptibility of our patients, those who have high risk underlying cardiopulmonary disease in particular, are those who we might recommend in these middle ranges, considering these acute mitigation measures. And then you also want to sort of layer in this idea of chronic exposure. As we discussed earlier, one single acute event isn't necessarily the only way that air pollution may affect us. So those who are maybe more vulnerable to air pollution, so they're going to be exposed on a repetitive basis, you might think about employing long-term mitigation strategies. Last, we're going to consider briefly effect modifiers. So these are all things that we're probably a little bit more comfortable with. And I will start by saying that regarding the question of dietary supplementation and medications, there's really mixed data, and it actually suggests a signal towards harm. There, of course, is a role for a balanced, healthy diet in general, but any specific changes that are made with the goal of reducing the effects of the adverse health effects of air pollution exposure are unlikely to be beneficial. That said, here's an area where we can really be powerful advocates, and that is doubling down on our smoking cessation counseling and therapies, because this certainly leads to a multiplicative risk. And then continued management of comorbidities. So we should be making sure that all underlying comorbidities are optimized in order to reduce the harmful effects of air pollution. So now we'll take it back to our case, and we're going to put it all together again and see if now, with the context of our construction worker who is working outdoors during these heavy smoke events, underlying COPD, ongoing smoking, coming to you with a COPD exacerbation that you believe is due to air pollution, what might you tell him? What might you recommend in order to mitigate his risk and to address the more acute effects? No takers. Nobody wants to help him feel better right now. Nobody wants to tell him how to prevent this from happening in the future.
Gina says smoking cessation, home air filters.
Great. Gina, a wonderful primary care doctor. So I love it. Those are awesome. We should absolutely be having conversations about smoking cessation. Again, let's not forget our basics, right? This is an area we should hopefully all feel comfortable with. Other things to think about: you could educate your patient on air quality. I think it's important that we not assume that they all know what how to check air quality or what it might mean. We, of course, would want to optimize the treatment of COPD, both the acute exacerbation and make sure that they're on appropriate long-term controller therapies. Continued smoking cessation counseling is going to be vital. We could recommend a HEPA air purifier at home. If they can afford a regular HEPA air purifier, great. But if not, maybe see if they could get a box fan and put a HEPA or a home air filter on it. Even though the majority of the exposure may be happening at work, to whatever degree we can decrease the cumulative exposure might be beneficial in our patients. Also, we could consider discussing the use of an N95 respirator when outdoors, especially during high air quality periods or poor air quality, high AQI events. This is something that I think we all know is not necessarily the most comfortable, but if we're leading to air quality that causes people to feel like they're almost suffocating due to their underlying lung disease, then it may be worth considering. And then lastly, I think it's important that we never understate our roles as physicians and advocates, and see if we may be able to assist with potential job accommodations. And I think that this is something that Cora or Dr. Sachs might be able to help us learn a little bit more about at the end of today, but I think that we may not consider this as often as we probably should. And with all that, I'm going to wrap up here and just remind you that we discussed some of the major sources of air pollution and the criteria pollutants. We discussed some hypothesized mechanisms for harm and the major adverse health effects associated with air pollution exposure. We talked about how we could think about vulnerability and susceptibility to contextualize our patients and risk stratify them. And then we put it all together and came up with some frameworks to think about counseling our patients on air pollution. And with that, I will finish here, and I'd be happy to take any questions. I'm also happy to let everyone go on break.
Awesome. Thanks so much, David. I actually had a quick.
Oh, sorry, go ahead.
Oh, who is just whoever.
Oh, that was me, Alan. I don't, but you can go ahead. Sorry.
Go ahead, Alan. Go ahead, Alan.
Cool. No, I was just wondering, thanks, David, for the awesome talk. In relation to like trajectory, like with more fires, global warming, and overall pollution coming up in the next 10, 20, 30 years, when we're practicing kind of during the meat of our practice, what have you seen any aside, from talk, but have you seen any like green new project or anything coming up in the pipe works for healthcare at least that we could be bigger advocates for, or anything that like we could be doing big picture wherever we end up practicing about improving the quality of the environment, quality of air pollution, or decreasing air pollution, kind of on that front, if you have any thoughts or if you came across anything like that.
I love that question. I don't know that I have great specifics there. I don't know if Dr. Stack or Dr. Min have anything that they would throw out there for folks to consider.
Yeah, I think that advocacy is something that we don't talk enough about in our medical educations, and Esther's gonna, I know, share some resources that people can think about. There is a physician advocacy group for environmental health in Washington State. And I think just getting involved and being more vocal advocates can be really important too. But I think that it's something I'm still struggling to learn how to do, and how to effectively risk communicate with patients in the community in general.
Has there been any, like in red states, like I'm originally from Texas, like which seems to be, obviously they have a little more pushback when it comes to climate change and accepting some of the things that kind of are more mainstream. Have you seen anything like in purple states or any actions that have been successful in kind of like switching that mentality of, hey, this is make it less of a political thing, but more of a like a healthcare improving wellness? Any actual like results from kind of like moving that dial from one position to another that you've seen before?
I can speak to some of the conversations I've had, at least within Washington State, but potentially in counties or in rural areas or areas that just might not be more thinking that climate change is not a science and something else. And so I think when you start talking about specific hazards, like actual like flooding or like people see it, they feel it, they're part of the community that feel it too. And so when you get hazard specific, I feel like that opens the door a little bit more than just saying the atmosphere is warming, greenhouse gases and everything. Once you start moving up, kind of it becomes abstract. I think that's where I see kind of doors kind of starting to close again. And so the more you can relate it to specific concrete examples, I think that really helps. And then going to that question about, some things you all can do as advocates of your own and as physicians. I have some examples that I'll go over in my slides as well, but really thinking about, like, for example, the wildfire smoke, that was an emergency rulemaking process. They were accepting public comments. And so as physicians, you could really talk about the importance of having these measures, especially for those that are more vulnerable and more susceptible. And so that could be like one way to be, really active in the space of supporting some of these more precautionary measures, if you will. And then there are other groups that might even think broadly, not just about like the health or the healthcare itself, but thinking broadly about, okay, who's making these decisions? Because physicians have so much weight in what they say in our society, I think people will really listen if you think about and really talk about some of the importance of incorporating this into the various different decision-making spaces, whether that's within a healthcare system or within your local government or state government, et cetera.
Awesome, thank you.
I want to make sure that we have time for folks to go on break. And does it sound, David, do you think it's reasonable to maybe say 7-minute break, come back at like 10:18?
That sounds great. Yeah.
Okay, perfect.
I think we have enough time built in, so yeah.
Perfect. While folks are on break, my question for you is, it's interesting to hear that the air quality index only takes into account like when any like one particular pollutant is high above that threshold. Do you know of any, like, do any of like the home sensors or like other websites take into account like multiple pollutants for patients that are particularly like at high risk?
So yeah, I see Cora.
I don't know of any composite scores. Certainly if you go to something like Air Now, it will tell you what the individual level of each pollutant is. And I think the other thing, again, that David nicely covered is that really those levels are these arbitrary categorizations based on regulatory limits, and don't necessarily correlate linearly with your risks of disease. So it's really kind of an imperfect method of communicating what the air quality is, but it's kind of our best way right now. But I think there needs to be better ways, and especially, taking into consideration what are those risks of delayed exposures from accumulative from what was the air quality yesterday and a few days ago, and putting that into context and being able to tell people.
Awesome, thanks. Great, so everybody will be back at 10:18.